So it's a great pleasure for me to introduce Dr. Madhavan Pashardi. He and I have known each other a long time going back, as I'll describe, but let me tell you about him first. He was born in Southwest India, which is he describes as the San Diego of India, the southwest corner, and very beautiful down there. He grew up speaking Malayalam rather than Hindi, and I think has always felt himself a little bit of a different person. He went to medical school in India and got his general surgery boards there, as was the requirement, before doing specialty training in neurosurgery. That whole process was 5 years after medical school. And after becoming credentialed in neurosurgery, he went on faculty at the University Kerala there in southwest India. Although he was on faculty, he still felt that he didn't have the ultimate knowledge that he needed to be the surgeon he wanted to be. So he petitioned to go to get training in England, and he went to Southampton Neurosurgery Institute, and also did time at the Old Church Medical Center, which is in the suburb of London. From there, he still felt he didn't have as much training as he wanted, and he applied to training programs in the United States, where he was accepted into a program by my then predecessor there, Dr. I'm sorry.
Eisenberg.
Yeah, Howard Eisenberg, right. And Howard Eisenberg was a very, inspirational leader down there. He had a very dynamic program. I joined the program, and when I joined, Madhavan was the chief resident. So as I came on board, it was Madhavan who showed me where the levers were at UTMB, and how to get things done at UTMB. And I think we struck off a great friendship because we were eager to teach each other, and I don't think we've ever held back. I won't say criticism, but questioning each other's decisions and that sort of thing. Madhavan is a bit of an iconoclast, and he's a mechanical engineer. I think he originally wanted to do mechanical engineering, but was influenced by his father that there were more opportunities in medicine. So he's put together mechanical engineering and neurosurgery in this spine fusion system that he's developed. This is in the vein of his iconoclasm. It doesn't follow the polyaxial head rod constructs. He was dissatisfied with their stability, and then looked for a more mechanically sound system based on plates. And this is something of an unusual, out of the ordinary progression. And I think you should really listen carefully to some of the advantages this system he's developed may have. So Madhavan, can you take it from there?
Yes, thank you. Good morning to everybody. First of all, I want to thank the Department of Neurosurgery and especially Dr. Nada for giving me this opportunity to talk about the uh, system that I've been working on for the last 20 years. Uh, can I start the slides?
Yeah, can you share your screen?
Yes, okay. Um, how do I share this?
If you hover above the top of your screen, there should be a little drop down that comes down where you mute. And it should have a screen share option.
Okay. Share video.
Yeah, I think you're sharing.
Oh, okay.
All you need to do is put your presentation up. Yeah,
Okay.
okay.
Can you see that?
Yeah, we can see that.
Okay.
I,
I'm going to put it over. Okay. So that's what I'm going to talk about today, the Unimax, or the Universal Multi-Axis Plating System. I started doing spine surgery with pedicle screws using plates. I was using the Steffi plate and the Simmons plate. And then I moved, like everybody else, I moved on to the rod system. But always I had an idea, desire to go back to the plating system, because in my mind, the plating system resisted the torsion problems that are inherent with the rod. And so about 20 years ago, I started working on this, and the main ideas were to be able to do multi-level instrumentation using plates. And the other thing I was concentrating was to make it multi-axis, because we had to deal with the different pedicle angles. And also, it would be nice if we can bend the plate in two planes, that front and back, as well as to the side. And I'll show you how that became a possibility. Um, this work was started about 20 years ago, but the first publication was only last year, and this was with the help of Dr. Nada. And as you can see, two of the four authors are from your department, and this will give you some idea about the various aspects of this system. Now, if you go back to the history of pedicle screws, today, most of the spine surgeons do some kind of pedicle screw instrumentation as part of their practice. The whole thing was started in the 1960s, and the credit is given to Raymond Roy Camille for having started the first pedicle screw. He is an anatomist who turned into a trauma surgeon, and apparently in one patient, after trauma to the spine, the spinous process and the laminae were all gone, and he had to find a way of stabilizing. And using his knowledge in anatomy, he thought that the best way would be to go through the pedicle into the vertebral body and stabilize it. So he did that in 1963, but he published it only in 1970. The first pedicle screw system done in this country is by Paul Harrington, and he did that in 1967 and published in 1969. He did the pedicle screws on L5 and wired them to the rods that were used for distraction and reduction of spondylolisthesis. So there we are. The pedicle screw system was started in the 60s, and over the next 50, 60 years, uh, there were several brilliant developments in this area, which made the system easier, safer, and simpler. The first change was to move away from the plating system because Raymond Roy Camille did his first procedure with the pedicle screws and Sherman plates. And then Arthur Steffi here promoted the plating system, and many others took on that. And so all the earlier cases were with the plate. But multi-level instrumentation with the plate is a challenge. And so slowly people started using the rods, which can bend and accommodate multi-level instrumentations. And then the monoaxial screw head changed to the polyaxial screw head, which made the surgery a lot easier. And then the various navigation systems came into the field and made the surgery much safer. And then people combined these new two developments and started doing the procedure through minimally invasive techniques and reduce the need for open surgery significantly. So the most common procedure done today for the pedicle screw stabilization is the minimally invasive rod system with the polyaxial head. It is simple, safe, and very pleasing for the patients and the surgeon because the incisions are smaller and the blood loss is less. And but they have some limitations, and the question we have to ask ourselves is, do we accept these limitations as unavoidable, or do we mm, look for more solutions for that? And so before we go into that, we have to look at what are the limitations that we have to consider. The first one is the suboptimal rigidity and stability. The junctions in the polyaxial pedicle screw with the rod are not very tight. For example, the kind of hemispherical bottom of the pedicle screw head is sitting on the pedicle, and it is not a tight junction. And so also the plate, the rod that goes into the polyaxial receiver, that's also not fixed very tight. So the system lacks in that respect some stability. And the next question is, what about the pull-out resistance? For the pull-out resistance, it is nice to have robust triangulation. This has been shown by many investigators, and the pedicle screw with the rod does not have a robust triangulation, especially when done through minimally invasive procedures. And it depends purely on the strength of the threads for the pull-out resistance. And then the next thing we have to consider is the efficiency of the posterolateral fusion. The whole instrumentation is crowding in the posterolateral gutter, and so that interferes with a very strong posterolateral fusion. So what does that lead us to? It leads us to a system that is not very rigid with poor posterolateral fusion. So the combination makes the stabilization from the back little weak, and this gives the surgeon then the consideration to do a discectomy, which makes the whole construct a lot weaker, and then go ahead and do an interbody fusion or do a 360 fusion. So that the whole point of the posterior instrumentation with fusion being weak is forcing the surgeon to consider having to do more surgeries further anteriorly to support the anterior and middle columns. result of all these things is that this construct is weak, and in moderate to severe osteoporosis patients, this is really contraindicated because of the risk of the implant failing. Another thing you have to consider is when you are doing the procedure minimally invasive, severe stenosis will pose a challenge because indirect decompression may not be enough in those situations. You probably have to go there directly and decompress. So again, you can do the open procedure with a screw and rod, but that has all the other limitations that I already explained. And so the need for direct decompression will lead to the need for a more rigid fixation. The other thing is the dread of the adjacent level pathology. In these instances, you have to open up the whole previous surgery, remove some of the previous instrumentation, and then in the process, destroy some of the fusion that has already taken place. So the instrumentation into a junctional
Excuse me, Madhavan, are you advancing your slides?
Oh, no, I'm not. Sorry. Okay. Okay. So that is the and finally, I have to bring up the question of the micromotion. The micromotion, there is a lot of argument in favor of micromotion and against micromotion, and the question is whether too much micromotion is going to be a problem. And there is a good reason to think that too much motion like that can lead to pseudoarthrosis, implant failure, chronic pain, and even failed back surgery syndrome. So now that we know all these possible limitations, the idea is how we can overcome those things. And the system that we envisioning should have better rigidity, and that involves tight connections between the various parts of the system. The connection should be very tight, and the connection between the screw and the pedicle also should be very tight. Improved pull-out resistance, and that is based on a rigid triangular fixation, and then interlocking those in a vertical construct. So those together will increase the pull-out resistance tremendously. And then you have to have the posterolateral area free for bone grafting. And when you get a strong construct and a good posterolateral fusion, you have not only accomplished strong posterior support, but that can indirectly give some amount of support for the anterior and middle columns, thereby avoiding the need for discectomy, interbody fusion, 360 fusion, and all those additional collateral surgeries that we don't have to do. And then again, when we design something, it has to be something multi-level instrumentation possible, and preferably with a plate, preferably with the rigid connections. And if we can reduce the spondylolisthesis and support the reduction through a easier way, that will be desirable. Then the dread of going into the adjacent level pathology, if we can somehow reduce that fear, that will be really good. Better sagittal balancing. One of the problems of multi-level rod fixation is the loss of the sagittal balance and resulting in flat back syndrome, which is another reason for failed back surgery and chronic back pain. The system should be able to give very good sagittal balance, and that is another goal. Um, and then through reducing the micromotion, the patients will be better satisfied. So with all these different needs in mind, um, we came up with this pedicle screw system. There is the triangulation at each vertebral level. So there is one screw on the right side, one screw on the left side, and they are connected with a horizontal plate. So that is at each level. I compare it to Lego pieces. So each vertebra behaves like a strong triangular fixed piece. And then you connect them with a longitudinal vertical plate, and that locks the whole system into a integrated um, system, which makes it very strong. And especially if you do multiple levels, the system becomes so tight that any one screw to move, it has to have some kind of accommodation from all the other screws. And so it makes it very difficult for the screws to back out. And so with this, you can even offer the surgery to patients with osteoporosis. And if you think about this whole construct, you can see that the system does not even depend upon the screw threads anymore. The structure is very rigid and strong by its own nature without depending on the screw threads. So this is the way we do it. There are pedicle screws on each side, and then there is a horizontal plate. That is a triangular, and so this is what I call the Lego pieces. There is a piece here, there is another piece, so these are each individual vertebra behave like a free piece, very well connected with the horizontal plate. And then you go and do the vertical plate, and this lock the whole system into one integrated unit. And here you can see that any one screw has a very poor chance of backing out without the whole system agreeing for that. And so this is an extremely stable construct, and that is what we wanted, and I think this system does that. And here you can see the screws are not polyaxial, they are monoaxial. And the multi-axis arrangement is done by the ball and socket joint on top of the pedicle head, screw head. So the undersurface of the head is very flat. And this is important because when that sits on the pedicle very tight, the translational weakness is eliminated. And that I think is a good quality for this. And then this is what I call the micro motion. I mean the cantilever cantilever motion that is allowed by the polyaxial head rod fixation. I have exaggerated the thing. It's not going to move so much, but there is that type of movement possible, and that is why the middle and anterior columns have to be supported when you do this kind of instrumentation. In the system that we designed, there is the horizontal plate which has a flat surface. There is the vertical plate that has a flat surface, and it is very tightly approximated with a flange nut. So when you have a flat surface against another flat surface, this horizontal plate cannot rotate on its long axis, which is which is the basis for the cantilever movement. So if this fixation is done tight, there is practically no cantilever motion at this level. And then the base of this I call the square bolt. Base of the square bolt has the ridges on both sides that lock onto the horizontal plate. So when the vertical plate is put on this and fixed tightly, the vertical plate cannot rotate on the horizontal plate like a clock handle, a clock needle, because this will not allow that, the locking on the undersurface of the thing. So between the screw head, this arrangement, and the flat surface against the flat surface, the junctions are very tight, and it will not allow significant micromotion in any direction. And the interlocking of multiple horizontal plates with the long axis also makes the whole construct very, very stable. And that gives enough support not only for the posterior column, but also to the anterior and middle columns. And that's this is the ridge on the bottom of the square bolt that locks onto the horizontal plate. So this is the practical benefit from this. This lady came in a wheelchair with tuberculosis of the vertebral body, L5 vertebral body, completely destroyed. The discs are maintained. So we have a weak anterior and middle column here. What we did was a strong posterior instrumentation with, I call this picket fence. Instead of just two plates, I use 4 plates. Now we can also stack them. So you can go to 8 plates if you want. But the whole idea is to make the posterior instrumentation so tight and rigid that these screws won't have any cantilever moment, and indirectly it gives support for the middle and anterior columns. And it did work, because this patient got out of the wheelchair and started walking right after the surgery, and she remained stable as long as I followed. She was from Mexico, so I lost her follow-up after about a year or so. This is another case, a similar thing. There is a vertebral body destroyed with a neoplasm, and again we did the instrumentation using the picket fence type posterior plating, and you can see the posterolateral fusion beginning to get strong, and over the months it became really strong. And this patient also did not require any anterior or middle column support, and he did well. This is a case of spondyloptosis. You can see that the L5 vertebral body is almost dropped off the sacrum, and we address this problem with the radical decompression followed by L4 to S1 plating, again using the picket fence type 4. Today I stack the plates also, but the thing is, this was strong enough to support that thing, and you can see the very strong posterolateral fusion, and he did very well. And 14 years later, I saw him about a few weeks ago. 14 years later, and about 100 pounds extra weight, he is still doing fine. He cannot touch the toes only because of his physical, not because of the spine problem, because of his obesity. This is another instance where the patient had a benign, highly vascular tumor that was eroding in the spine vertebra, and also there was a intra spinal extension. Patient presented with paraparesis, and we did radical decompression here, but the vertebrae were not stable enough to have the pedicle screws. So we did the what I call the long distance pedicle the fixation, two above the abnormal vertebrae and two below. Today I would have stacked them, and those days I was not doing the stacking, so we did that, and still this patient did very well. I followed him for about 10 years. I have not seen him for the last 2 or 3 years. He started walking normally and behaving normally. And the one of the other things I wanted was to be able to do multi-level, and that we accomplished by being able to slide the square bolts along these holes in the horizontal plate, and so by aligning them up, the square bolts, we are converting a very irregular pedicle screw arrangement into a very surgeon-friendly straight line. And the other important thing is to be able to bend the plate exactly like you want, so that you can give the lordosis you want to give the patient, and you can start bending it backwards toward the thoracolumbar kyphosis. And all that can be done by bending this vertical plate appropriately. This this will avoid the flat back syndrome with chronic pain. And also, there was some study that if the sagittal balance is adequately maintained, junctional instability will be less. And so that's another benefit from having the proper sagittal balance. And here there is another way of protecting the junctional level. If you want to protect the non-fuse facet on top, there is a offset horizontal plate that doesn't sit over the facet joints, and you can use that, and you can see the very strong posterolateral fusion from L4 to all the way to the sacrum. And that is a very important step in this procedure, because this is the only fusion that you're doing, and you have to do that very meticulously so that there will be some strong fusion. This is the horizontal plate where you can slide the square bolt from side to side, and between the multiple levels you can line them up. And you can also see the locking ridges on the bottom that locks into it. So that will prevent the clockwise movement of the clock handle type movement of the vertical plate. This is stacking. For a long time, we were not thinking about stacking. And about 3 or 4 years ago, we started doing the stacking, putting two vertical plates. And that has brought us some new benefits for the system. For example, you can bend the plate sideways now, not only in the anterior-posterior direction, but you can bend them by what I call the relay plating. This is rigid enough. As long as you tighten each junction adequately, the system is very rigid, and it will allow bending the plate sideways. So in some fixed scoliosis, when you cannot get straight line, you don't have to give up. You can use this arrangement like the crocodile walk, just from level to level, you decide whichever way you want to go. This is another advantage from when we started doing the stacking. Extension to the junctional level, you don't have to open the previous instrumentation at all. All you do is open up the two square bolts here and put a new piece onto it, like putting a Lego piece. And that is a breeze when you think of addressing the junctional pathology. Micromotion. Okay, the micromotion, there are arguments in favor of it, saying that yes, you cannot have stress shielding, you have to have some kind of load sharing for the bone to heal. But in practice, if there is too much of the motion, it interferes with the fusion, creates pseudoarthrosis, chronic back pain, and when the fusion is not solid, the implant will fail. Either the interbody implant will settle into the vertebral body, or the rods or the screws will break, and this will also lead to back pain. Uh, with reference to that argument in favor of micromotion or against micromotion, I was able to find one article, and this is the only one dealing with this problem, and this is published by Davlik in 1993. And he stated that if there is no internal fixation, the fusion rate is 65%. If there is semi-rigid pedicle screw fixation, there's 77%. And if there is a rigid fixation, the fusion rate is 95%. And he also showed that the patient satisfaction more or less mirrors the fusion rate. And so if you go with this um, idea, the more rigid fixation gives better fusion as well as better patient satisfaction. This just to give you some kind of instability that the rod polyaxial screw can do. This is sliding to the side. You can have sliding anterior posterior. And like I showed you earlier, the cantilever type of problem. So in my experience, I have seen this, and I'm going to just show you one example. This was a failed back surgery where the fusion failed, and you can see the interbody device is burrowing into the vertebral body above and below, and that has resulted in pseudoarthrosis and the implant failure. The rod is intact on one side, but it was broken on the other side. When there is no good fusion, the implant is not meant for lifelong support. The bone has to take over the support after some time. If the bone fails to do that, the implant will fail. Now, question is, why is this? Nobody is doing this procedure that we took so much pain to develop. And first answer to that is failure to market. I can convince myself a lot of things, but that's my weakness. I cannot convince others what I really believe. And so the marketing has been extremely poor. The other thing is this system is not compatible with minimally invasive techniques, and most of the spine surgeons want to be able to do the minimally invasive way, and so that's why it's very difficult to market something like this. And the third reason is the surgical anesthesia time, blood loss, and other problems that are common with any open surgery. So the fact that you have to do open surgery, the fact that it is not minimally invasive, there is no way this can be done minimally invasive, and the fact that I cannot convince other people to believe what I believe. This is a patient, a 60-year-old man who was in the emergency room, unable to walk, urinary incontinence, um, and he was legally blind, and this is what he had, the osteoporotic fractures of 3 and 4, and tight stenosis. I did the surgery on him in this February of this year, and this is the L5 fracture. It's scary to think of putting pedicle screw through that. but my system, the system that we use, it was because of its interlocking stability. I did use it, and um, he did very well. He was able to walk post-operatively, and again, this is the most important part. You have to do the posterolateral fusion very religiously, otherwise the the plate will fail. Um, this is a patient that I did surgery several years ago, and you can see osteoporotic fracture of almost all the lumbar vertebrae here. So I went from L1 to S1 plating using this system, and um, the whole system is stable, and it did allow the posterolateral fusion to support adequately. And this is the reason why I'm saying that you could offer this in osteoporotic patients also, provided you do good posterolateral fusion. And since the implant is not crowding in that area, the the chance of such a fusion healing is very good. The square bolts come in two lengths. One, the longer one has a waist where you can break it off, and this can be used for to make spondylolisthesis reduction really simple. For the displaced vertebra, you use the longer square bolt, and then when you tighten this, this vertebra will come up. And I don't do any discectomy. I just do this, and it does work. And also, the hole here, you have to adjust in such a way that the square bolt is on the lower portion of the hole, because when you raise it, you have to be able to distract it also a little bit, because in spondylolisthesis, it's not only the listhesis, but there is also a sagittal angulation where the posterior borders are closer together than the anterior borders. And so you should be able to distract. See, this is a kind of a sagittal imbalance here. The posterior border is closer. Not only it is listheus, but it is also closer here. So the procedure involves distracting it a little bit and then lifting it up. And before you do that, you have to do adequate decompression of the facet in here so that the facet won't work against you. And then you can get full reduction without doing any discectomy. I don't do discectomy on these things. Just use the brute force to pull it up and distract it, and through the screw and nuts, and it will come. And any rotational element of rotoscoliosis, it has to get corrected automatically when you do this instrumentation, because when you tighten the nut here, it's pulling the rotated vertebra back into the vertical plate, and if the rotation is very very bad, you may have to use the longer square bolt. Otherwise, I'm sorry. Um, Otherwise, the regular square bolt is enough if it is mild rotational deformity. Um, this is a 80-year-old female who came with full-fledged cauda equina syndrome, and she has all the problems: listhesis, stenosis, everything, and osteoporosis. Um, what I did was do a L2 to S1 decompression and posterior fixation, and so the decompression is adequate here. The listhesis is not completely corrected, and that is because sometimes there is the osteophyte to osteophyte connection here. So those listhesis will not be, we won't be able to reduce that. But with adequate decompression here, removing the facets and lateral gutter, everything, these patients do well, even if the listhesis is not completely corrected. She came back a few months after the surgery, after she fell down and fractured the L2 vertebra and developed a large disc herniation. So I had to go back in, and this is what I did. I did not have to open the previous instrumentation or anything. All I did was opened up the 2 square bolts here, decompress here, did the discectomy, and put the new plates, just that one level addition. And this is what I call the relay plating. So this is the just so the junctional pathology correction is quite simple using this relay plating technique. And this is we can still maintain the lumbar and thoracolumbar curvature the way we want it. This is the added portion, and this is the old portion. And you can see in the AP view, the relay plate is a little angled, but that doesn't matter as long as the sagittal balance is maintained, and as long as these nuts are very tight. This is a rigid fixation. You can see the posterolateral fusion getting strong now. Some amount of scoliosis correction is possible by distracting on the concave level and compressing on the convex side. But I have stopped doing that now, because with the adequate decompression, you don't have to correct this degenerative scoliosis. You can just use the relay plating, and that should do. The patient satisfaction is, X-ray may not look as good as you want, but the patient is satisfied with good adequate decompression and good fixation. This is the same patient I told you earlier, the one with who was legally blind and had the L3 and L4 fractures. I just want to go over the surgical steps that I did on this patient. This is the first stage of the surgery. You have to expose the transverse process adequately and decorticate them properly, because that is a very important step. And then I do the laminectomy without using the high-speed drill. I collect every bit of the bone, and especially when there is a lot of facet hypertrophy, there is a lot of bone that you can collect and clean out all the soft tissue from that, and grind it up in a bone mill that we have. And then I take some bone marrow from the iliac crest and mix it up, and that is the bone that I use for fusion. I don't go to the iliac crest for harvesting bone. I don't use any BMP. I don't use any bone extenders. This is all the bone I use, and the bone marrow. And that combination with a gutter that is free, without hardware crowding there, gives a very good fusion. The second stage is the extensive decompression. I also decompress the recesses at each level, so that the nerve roots are also free. And after that, I put the pedicle screws and the horizontal plates with the square bolts already in them. And then the next, the final stage is the vertical plate. The final stage of instrumentation. Final stage of surgery is putting the bone graft in the roomy posterolateral gutter, and that completes the surgery. This is the bone from the laminectomy. There is no additional bone. There is no allograft, there is no BMP. And you get very good fusion like this L4-5 posterolateral fusion, and without any BMP or other agents. Going back to the same one where we saw that interbody device burrowing into the vertebral body, this is the failed back surgery, non-union, pseudoarthrosis, the rod was broken, and this is the revision surgery that I did on this lady, and she. This is what I'm going to show you is the first post-operative visit. Okay. This is the first post-operative visit, and I asked her how she was doing. She was very happy, and there's a little video.
Show me what you can do. I want you to really touch the foot. Yeah, that's good. That's good. I wouldn't be able to do that before. Yeah. I wouldn't be able to do that. They cannot do it.
So, with that good ending for the failed back surgery and for this patient, I am willing to take any questions you have. The patient satisfaction with this fusion without micromotion is really something that you will feel. Any questions?
Hi, Dr. Madhav. That was fantastic. My name is Ahmad. I'm one of the PGY4s. I just had a couple questions.
Okay.
Why is there a reason you went with the non-tapered screws versus tapered screws? And how much? So it seems that if you're stacking the plates on top of each other, how much profile do you need, like, to make sure that you have enough to close? Or that, like, does it create too much, take up too much space?
No, because the profile limiting factor is the height of the pedicle screws. So the central portion comes below that. So let me show you. Go back to. In here, this is the limiting the profile thing, the end of the pedicle screw. This comes about a centimeter below the pedicle screw level. So the stacking will not be. Actually, this is stacked. This is stacked. You can see the plate underneath here, and this is the top plate. And so that does not add to the profile significantly.
So do you do something special for the dissection, usually for the muscle dissection, or just like standard?
Just the standard dissection, yeah. I have a very good retractor here. I don't know if you can see the blade. That's a very powerful retractor. I release it periodically to prevent ischemic damage. But other than that, I don't have any special technique.
Madhavan, I want to say that I saw recently in our own practice here the incredible rise of these epidural abscesses with the discitis, and then epidural abscess and erosion of the body. And our present posterior fixation, as you point out, requires anterior stability, something to establish an anterior stability, because the posterior fixation alone does not carry the weight, which means that we have to put foreign material into this sopping mess of infected discitis, osteomyelitis in the front. So the possibility of doing something completely from behind, where you don't have to add foreign material, put foreign material into a pus pocket, seems to me a particularly attractive application for your mechanically more solid construct. Is that realistic, or am I imagining too much?
No, that is realistic. Because like I showed you here, there was a segment of whatever column where I could not put screws or stabilize or anything. All I did was put the plates, horizontal plates above the pathology area and below the area, and I linked it with the longitudinal plate. In the thoracic region, this was enough because the thoracic spine does not move a lot. In the lumbar region, you will have to stack it, and if possible, put additional plates on the side also. And with that, I think you will be able to handle it without putting anything in the anterior and middle column. Does that answer your question?
Yeah, yeah.
One last thing, sorry. Can they be navigated, or are they, or you have to do them with just fluoro?
What is that?
Can they be navigated with like an arm, or it can't be? How
Well,
can they use navigation?
the pedicle screws can be put in any way you feel like, and whatever is you're used to, you can do the pedicle screw like that. And then after that, it is not there's not a lot of learning curve here. You put the screws, and then everything else is a little carpentry after that.
Madhavan, I think it's a great presentation. Thank you very much. I had two questions that I was curious about and maybe get your opinion. What I like about the system is that you've essentially taken the three-dimensional problem of bending a rod by reducing it with the crosslinkers. It's a two-dimensional plate. Some of the questions I had, it seems to me that in order to do this with the crosslinker, you have to place the screws almost exactly mirror imaged to each other. Otherwise, you're going to have to torque the plate in order to meet the screw heads. Is that correct? And then the second question, something that I've understood about sort of the mechanics of the osteoporotic spine is that you can be too rigid. What I've seen more than breakage is I've seen problems where the rigidity of the construct causes the bone around it to shift and toggle, and you get this sort of lucency around the screws. Can you be too rigid in a situation like this? I guess that's the other question.
But that is there are two reasons why that happens. One is that the micro motion is allowed inside the osteoporotic bone, and the second thing is the osteoporotic spine. You go ahead and remove the disc and make it even more unstable, and then you put the pedicle screw in the back and then interbody device, and none of them are tightly fixed to each other. And so with the osteoporotic bone, there is a tendency for the screw to move inside. But when you avoid that micro motion, the screw cannot move, and all the stress, you can argue that all the stress is transferred to the either end of the whole construct, which can happen. But inside the construct itself, the screws cannot move.
Got
it. Okay.
Dr. Niemann, your point about the perfectly symmetrical screw placement, these screws do have a dome top, and so they accommodate different angles.
Yes, the screw has a hemispherical head, and the undersurface of the horizontal plate is kind of concave. So that goes into. Let me see if I can show you that slide. That can accommodate any type of pedicle angle. This one. See that? this is not symmetrically placed. There is a ball and socket type of joint between the screw head and the horizontal plate, and the screw can be in any way, but this the hole on the end of the horizontal plate is larger than the diameter of the screw, and so inside that this can go in different directions, and then there is a flat plate that goes over it to convert that into the narrow hole where the nut goes and tightens on the plate. So yes, you can put it in any angle. It doesn't have to be symmetrical.
But then on this side, is the position of the screw rigid relative to the plate? Because here it seems like there's some potential for toggling, for rotation of the screw axis relative to the plate.
Well, no, because of the ball and socket tight fixation here, and the nut going and tightening it against the horizontal plate, any amount of toggling here is prevented.
I see. Okay, all right, that makes sense. Thank you very much.
Okay.
All right. Well, thank you very much, Madhavan. I think it's food for thought that the things we're doing with the polyaxial head screw rod constructs may have some alternatives, and there may be special applications where this is particularly useful. I was thinking in particular of our problems with the spinal infection, and I think my thought was to maybe start there and try using a system like this in that particularly demanding requirement.
Yeah, I think really needing this will be in neoplasm, degenerative osteoporotic spine, and infection of the spine. Those three areas, this will really come handy.